A great observation results in innovative ideas that creates a positive change in patients' performance. Assessment in neurological physiotherapy is a process of collecting information about disordered movement patterns, underlying impairments, activity restriction, and societal participation of people with neurological pathology. It helps greatly in planning the intervention to its fullest capacity. Hello, Namaste viewers. Welcome to our channel PhysioHealer. Today's video is about learning a proper way to observe patient with neurological disorder and how your skill of observation can help to formulate differential diagnosis. What can you see in this picture? A person leaning forward on a chair appeared to be tired. Here, what should be your observation as a therapist? Forward stoop posture, maybe breathlessness, or having a back pain, or maybe headache? Your observation on the first impression can formulate an array of questions that lead your further assessment and shape your history-taking skills. Observation is the capacity of the individual to know the environment by use of their senses, concentration, and perception of the facts. It is a systematic and deliberate study through the eye of spontaneous occurrence at a period of time. Observation can be done in three ways: unstructured observation, structured observation, participant and non-participant observation. In unstructured observation, no attempt is made to manipulate or control the phenomenon. Observation is made in the natural surroundings and activities are performed in their usual course. Structured observation is done in controlled environment and mechanical aids are used to get standardized data. In participant observation, the observer joins the group and observe their activities. And in non-participant observation, observer simply observes the activity but do not take part in them. To an experienced therapist, observation begins during the first impression of the patient. Your observation must start when you first see the patient coming towards you through the door of your clinic. Listen first to the patient. Loud conversation outside the room usually indicates a patient well accustomed to attending doctors. From the sound made while walking and the manner of walking helps in distinguish unilateral dragging of the foot in hemiplegia maybe, narrow-based shuffling gait of Parkinsonism, or stumping of a dropped foot. Parkinson's patients are likely to halt at the door itself and make attempt to open it wider than necessary to get inside. This indicates inability to navigate through narrow spaces. Patient with ataxia may bump into door frame while trying to get in due to the inability to maintain balance and seeking wide base of support. Your next observation is when the patient walks from door to chair. Check the size and shape of the patient. Notice height, obesity, abnormal head size such as hydrocephalus, acromegaly or achondroplasia, and look for obvious skeletal deformities. This is also an ideal time to observe the gait. Look for any predominant attitude of the limb, presence of arm swings or any signs of fear of fall. On sitting down, observe the way the patient pulls the chair or whether they require any help to do so. Notice the effort and support required to sit down. Involuntary movements, tics and habit spasm will be more apparent now. Deviation of face to one side while talking or sudden distortion of one side of the face to which patient winches may indicate facial nerve palsy or trigeminal neuralgia respectively. Tremor of extrapyramidal disease appears as soon as the patient is settled, and some Parkinson's patients, due to intense akinesia, remain totally immobile and unable to rise when asked to do so. Also check for muscle wasting that appears to be obvious in limbs and upper body. Identify various facial changes while talking to the patient. Look for absence of forehead creases, diminished nasolabial fold, inability to close one side of eye, and deviation of mouth to one side to suggest facial nerve palsy. Exophthalmos and lid retraction occur in hypothyroidism. Drooping of both eyelids moment to moment indicates myasthenia gravis, or a fixed bilateral droop with wrinkled forehead occurs in ocular myopathy, whereas Fixed unilateral droop may occur in oculomotor nerve palsy. A unilateral fixed ptosis may indicate Ono syndrome, and absence of blinking is common in Parkinsonism. In lower motor neuron facial palsy, look for the eyeball turning up and out without closing the eyelid. Also listen to the volume of sound, the clarity of the words, and the content of the speech to identify dysarthria or aphasia. Patients with pseudobulbar palsy and occasional brainstem lesion often show incontinence of emotions, and they laugh or cry involuntarily and irrelevantly. Observational assessment in a patient who is admitted in hospital, either in ICU or ward, is a completely different situation. Here, patient does not come to the therapist, but rather therapist goes to visit the patient. In bedridden patient, first of all check whether patient is conscious and alert. Does patient look at you when you enter? Do they greet you? Check the lines and tubes attached to the patient and note the readings of ventilator. Check the preferred lighting of the room by the patient. Note that intense photophobia occurs in meningeal irritation and migraine. A patient with vertigo lies still, not daring to move their head. Patient with respiratory distress lean across the bed table. If the patient is sitting, do some postural analysis. It is easy to recognize the forward stoop posture of Parkinsonism, lateral slump of the hemiplegic, and swollen head as well as limb and fully supported posture of a traumatic brain injury. It is very important to correlate all your observational findings with history and other objective examination. In summary, here is the list of all the relevant points that need to be observed keenly in neurological assessment. Body build, pattern of movement, mode of ventilation, pattern of respiration, edema, muscle wasting, pressure source, presence of deformity, wounds, external appliances, involuntary movements along with associated reactions, posture and balance, and lastly, gait. Observation is the most important skill of objective assessment because it requires therapist knowledge to the subject and their cognitive and perceptual abilities at best to recognize and identify even a slight change out of normal. If you can spot it, only then you can examine it. Keep your baseline observation properly documented and note the changes regularly. A neurological patient must be observed regularly to recognize any sign of deterioration. It is preferable to assess and reassess the patient by the primary therapist, and any change or progression must be properly documented, as changes in a patient's neurological status may occur rapidly over a short period of time or more gradually over days or weeks. If you have any question or suggestion about today's video, then write in the comment box. Don't forget to like, share and subscribe if the video was helpful. See you next time. Bye-bye.